of order. Included in your packets are copies of the minutes from the January 15th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval.
So moved.
All right, I'll take that as a second.
Commissioner Khan.
That's Commissioner Khan on the phone. Anybody else on the phone? Okay. Any discussion? All in favor? Any opposed? They're approved. You've received the written updates from the centers, and Ben, do you or any center directors have anything you'd like to add?
So as you may have heard next door, I just wanted to be sure we noted that this will probably be Commissioner Falcone's last meeting. He has served more than 8 years with the Healthcare Commission as a representative from first Western Maryland, and then the Eastern Shore. And during that 9-year period, I think he's really seen the broad swath and sweep of the Commission's responsibilities, always discharging his duties with a great deal of thought, good humor, and commitment and support for the other commissioners. We're going to miss his contribution greatly, and I think it's very appropriate that we all thank him today. We would expect a new appointment over the next month or so. Should it not happen, I'll be very pleased to give him the same commendation next month as well. But thank you, Commissioner Falcone. Thank you.
Thank you, Ben, and thank you, Commissioners. It's been an honor serving with you all, but a more special honor working with this very talented staff that's worked so hard for the state of Maryland. People only knew how hard you are, that you work with the things that you do, as well as your time and dedication. So it's been an honor and a pleasure. Thank you all.
Ben, any other updates?
I believe we have one from
David and Linda. Okay.
I'm live here. All right. Good afternoon, Mr. Chairman, members of the Commission. I wanted to give you 2 additional items to the update that you have received in your packet. First one is that staff included in your material for today the information brief from the results it presented at the January Commission meeting regarding EHR adoption in local health departments and state hospitals. Also, on February 3rd, the Office of the National Coordinator for Health Information Technology, or often referred to as ONC, released a grant titled the American Recovery and Reinvestment Act of 2009, Advanced Interoperable Health Information Technology Services to Support Health Information Exchange. The funding opportunity announcement will leverage the investment made by ONC in their original 2010 HIE program that Maryland and a number of states received. This grant is intended to accelerate the adoption of information, including secure messaging, alerting, query-based exchange, and engaging the consumers in some sort of mediated exchange, which ONC is looking for states to propose. Interested applications are due to ONC on March the 6th. The award is supposed to be June 12th. The funding amount is for between $1 and $3 million. Staff, MHCC will be working with CRISP on the grant. CRISP will serve as prime. And we're looking forward to, hopefully, another winning grant opportunity for Maryland. There are a limited number of awards to point out. They're only projecting up to 12, so we imagine there'll be a number of states competing for this opportunity. And Mr. Chairman, this completes my addition to the update.
Thank you, David. Linda?
Commissioners, it's my pleasure to introduce a new addition to the staff of the Center for Analysis and Information Systems, Qian Zhang.
Hi, everyone. I came from a small consulting firm which is focusing on public health policy in Medicare. So I have plenty of experience with data analysis and claim data. And I am here working as a senior public policy analyst as in the Center for Analysis and Information System at MHCC. I'm very happy being here.
Thank you, Joyce.
Thank you. Any other updates? Very good. All right, we'll go on to our first action item. Kevin McDonald will present the staff report and recommendation for a Certificate of Need application filed by Brook Grove Rehabilitation and Nursing Center for the construction of a 70-bed wing to replace 48 beds in an older wing and add 22 temporarily de-licensed beds acquired from another facility in Montgomery County.
Thank you. Brook Grove Foundation operates Brook Grove Nursing and Rehab Center as part of a continuing care retirement community in Sandy Spring in Montgomery County. Unlike a number of CCRCs around the state, all of their nursing home beds are received through the CON process and are not limited to use by CCRC members. This project is to demolish a 48-bed wing that was developed incrementally over years from the late 1800s, starting in the late 1800s and completed in 1970. The newer part of the building was completed in 2000. In addition to replacing those 48 beds, the proposal is to add 22 beds that are currently temporarily de-licensed, and they would be purchased from National Lutheran Home and Retirement Village at Rockville. The cost of the project is about $25 million, slightly over $25 million, would be financed through a $24 million mortgage and the balance in cash from the applicants. In terms of the background and context for the project, although this is an existing facility using beds currently in the inventory, the applicant is still required to speak to the continuing need for these beds. The MHCC's updated inventory and need projection of corrected and updated need projection for nursing home beds in Montgomery County for 2016 shows a rather significant surplus of beds, almost a 1,200 bed surplus on a projected need for around 3,700 beds. At the same time, the jurisdictional occupancy in Montgomery County is among the lowest in the state at 85%, about 3 points below the statewide average. Referencing the state health plan, however, speaks to the aging stock of nursing home beds around the state and says in a policy that the Commission will assess the impact of nursing home physical plant age and design on quality of care and encourage facilities to develop replacement facilities where needed. Historically, MHCC practice has been to allow facilities that are operating at a 90% or higher occupancy that meet other standards and criteria to replace and relocate beds in the inventory by purchasing temporarily de-licensed beds within that jurisdiction. And despite these occasional reallocations, the provisions in the CON regulations allowing facilities to temporarily de-license beds has succeeded in fostering a gradual shrinking of the supply of nursing home beds in jurisdictions that have surpluses. In this case, the applicant has documented a strong occupancy, over 90% the last couple of years, and close to 90% for 5 years. Some of that driven by changes in hospital incentives regarding admissions and readmissions. Their occupancy also, if you look solely at the newer part of the building, is a good bit higher, about 93%. In terms of quality, in public reporting, the facility's quality was average to slightly above. Looking at viability and financial feasibility, the latest 2 fiscal years showed a positive operating margin. The projections post-project show small operating losses that are covered by non-operating income, producing overall positive bottom lines. Their audited financials demonstrate the availability of the cash contribution, and the applicant is working with M&T Bank for that mortgage. Staff analysis, summing it up, the proposal does not seek to increase the total number of nursing home beds licensed in Montgomery County, instead using beds currently in the inventory, reallocating them, and reallocating them from National Lutheran to Brook Grove. The applicant facility has maintained a relatively high occupancy and has described a growing need for short-stay nursing home beds to serve Medicare qualifying patients in need of rehabilitative services. And the proposed project allows the replacement of Brook Grove's 48 beds, at least some of which are operating under life safety code waivers, and the expansion of 22 beds enhances the operational efficiency and financial feasibility of the project. In the staff opinion is that the proposed project is in compliance with the applicable criteria and standards in the long-term care services chapter of the state health plan, as well as with the CON criteria, and recommends approval with the following conditions. Brook Grove Rehabilitation and Nursing Center will maintain the minimum proportion of Medicaid patient days in its 1998 Memorandum of Understanding with the Maryland Medical Assistance Program, agreeing to maintain the minimum proportion of 44.93% of Medicaid patient days in its 190 licensed CCF beds, or execute a modified Memorandum of Understanding in accordance with Nursing Home Standard COMAR 1024-08-05A2 for all of Brook Grove Rehabilitation and Nursing Center's 190 licensed beds. Representing Brook Grove today are Vice President Dennis Hunter and David Shea, the Controller. If you have questions.
Let me just get a motion first. Do I get a motion to approve the certificate of need?
So moved.
Second? All right. Any questions or discussion?
No.
Okay. All in favor?
Aye.
Any opposed? You have your CON. Next agenda item is the nursing home short stay survey results, and Carol Christmeyer will present the results of this survey.
Thank you, Commissioners, for the opportunity to present this information today. I haven't spoken with you about the nursing home experience of care surveys for some time, and today I'm going to focus on the short stay survey results. As a note, this presentation has changed considerably from the slide deck you received last week, so please refer to the slide presentation that's in front of you today. First, a little bit about the history of the Maryland short stay surveys. We've been doing the family survey since about 2007, and several years later, we noticed an increasing number of short stays in some nursing homes. And when we looked at MDS data, that confirmed that, in fact, that was occurring. We have had collaborated, and we're still collaborating with the Agency for Healthcare Research and Quality, the AHRQ, on several survey projects. And they asked us to assist them in further testing the short stay survey. They needed additional surveys to validate the measures and some of the composites. And we agreed to do that, and that was done beginning in 2011 as a pilot. What constitutes a short stay? For the pilot, we followed the AHRQ survey guidelines. We looked for nursing homes with an average of 25 or more short stay discharges per month, a resident stay of at least 5 and less than 100 days, or 100 days or less, and the resident was discharged home in the last 3 months. Initially 80 and now 79 nursing homes have met the criteria and have continued to participate in the survey. Short stay in Maryland seems to be an increasing market. Discharges, as you see, have increased 30% in just 2 years. There are 7 nursing homes that are hospital-based and focused exclusively on short-stay residents. In addition, some nursing homes aggressively market to the post-acute population and attract larger numbers of short-stay residents. The Maryland all-payer modernization model will likely further increase the use of short-stay. In addition to short-stay just increasing because of the baby boomer generation. This is a profile of the 70, I said there were 79 nursing homes participating. 72 of them are both long and short stay nursing homes, so they take both sorts of residents. Generally, they are larger in size, located in urban and suburban parts of the state, for-profit, and corporately affiliated. The staffing is shown there, and their staffing tends to be, for this group of nursing homes, 4.3 hours per resident day versus 3.99 for non-participating nursing homes. And you can also see the hours for licensed staff, and that would be RNs and LPNs per resident day. That also tends to be slightly higher. There's a caution about the staffing numbers, however. These are a snapshot in time. They're collected at the time of the annual survey, so they are not a picture of what happens each day in a nursing home, nor are they necessarily a picture of what each resident, the kind of care or the hours of care each resident would receive on a daily basis. The other 7 nursing homes are short stay, located in hospitals. They are much smaller in size. They average less than 30 beds. They are still primarily urban and suburban located. 2 of them are primarily rural. They represent 12% of the total facilities in the participating group, 100% nonprofit and health system affiliated for the most part. You can see the total staff in these nursing homes are considerably higher, both of the non-participating nursing homes and also from the other nursing homes in the sample. And these nursing homes do take a much higher acuity because the resident is transferring directly, sometimes directly from ICU into the nursing home. Again, same caution applies to the staffing numbers. Okay, returning to the results, this is a 3-year trend of the results. I first looked at overall rating of care. I don't have an explanation for the drop in 2013. And perhaps that's the aberrant year, because if you look at 12 versus 14, they are quite similar. 13 was an aberration. We looked at response rate, resident characteristics, and nursing home characteristics, and really can't account for this change.
What's the N behind here? How many responses make up most of these?
About 5,000 responses overall.
Thank you.
These are the domain ratings. The domains are similar to the ones we see in the family survey. Care provided, communication, personal choice, activities, environment, and transition to home. Transition to home is a category that's unique to this survey, and I'm going to talk about that on a later slide. Again, you see the trend of 2013 showing higher scores. Question? Sorry.
Is there any benchmark information? I mean, I'm just wondering how this compares to others who have taken this survey.
GARC has not released national results. When they analyzed our data, it was compared to some nursing homes in the University of Pennsylvania, and I don't have that information. I could probably get it from the researcher who did it.
But ARC overall hasn't released any sort
No.
of national benchmark or anything. Okay, thank you.
Transition
If I could-
questions. I'm sorry.
If I could ask, Holleran Satisfaction is a company that does satisfaction surveys. Holleran, they have one of their questions is that did you spend time did you have a short stay in the nursing home on your campus, and how were you satisfied? How was your success? And I think the numbers scores are probably in the 80, but it was just that one question, not the different domains here. So. Yeah, well, they do about mostly CCRCs, the nursing home CCRCs, about 400 facilities nationally, mostly the East Coast.
The overall scores on the short stay survey do tend to be lower than they are on the family survey, but we are surveying family members responsible parties versus residents who actually experience the care. Didn't mean to do that. I guess I'm ahead now. The transition questions might be particularly useful in following transitions across care settings. For example, from the hospital to nursing homes. Because there are similar questions in the HCAHPS survey that is given to hospital patients. They address whether the person felt nursing home staff discussed if they would have the help they needed, information about symptoms to look for when they went home, what the medications were for, and that the person clearly understood the usage of the medication. Okay, so how do these nursing homes participating in the short stay survey compare on quality? In order to measure that, I selected from Nursing Home Compare 5 short stay quality measures and 5 long stay quality measures that look at similar or the same conditions. So the short stay measures are applicable only to short stay residents, that is those with a stay of 100 days or less. And the long stay measures are applicable only to long stay residents. But because all but the hospital-based nursing homes take both kinds of patients, we do have some comparisons. This can be somewhat confusing at first glance, so let me explain this slide. The left-handed table shows the results of the short stay quality measures, okay? So those only applicable to short stay residents. The right has the long stay quality measure results. The column shows the 3 groupings of nursing homes. So the first column, short stay, N equals 79, those are all the nursing homes that are participating in the short stay survey. The second column are all the other nursing homes in Maryland, so 144 of those. And the last column are all the nursing homes in Maryland. And so we're getting the state average there. And it's shown for each type of measure. I don't know. Turn the page here. Looking at the short stay measures of participating nursing homes, they tend to do the same or better than non-participating nursing homes and the statewide average. Pain and pressure also are essentially the same. The other scores tend to be slightly better. The same trend is seen looking at the long stay measures. Participating nursing homes tend to do the same or better, with one exception, than the participating and statewide average. So overall, these nursing homes appear to be giving slightly better or better quality. flu vaccine is the one measure which is different. None of the hospital-based nursing homes had enough residents to contribute to this particular measure. In fact, they all had zero patients or zero residents. So they are not included in the denominator for that, for the long-stay measure, for that one long-stay measure. For the others, they did have sufficient residents. Are there any questions about that one? We've been collaborating with HSCRC to use this information. We did begin the survey prior to the waiver modernization application, but when it was finalized in 2013, short stay results were included as a performance indicator, and it is being sent to CMS as part of the waiver evaluation. It is an annual survey, so it's just one set of scores. We're planning to continue to expand the short stay to additional nursing homes that can meet the baseline requirements. So the takeaways for this presentation are that improvement in transitions across settings can benefit providers, patients, and reduce costs because of reducing readmissions, for example. Expanding population of seniors will likely result in a greater need for long-term care. The all-payer modernization waiver supports early discharge and avoidable readmission. And as a result, HSCRC is using this as a performance measure. HSCRC is also beginning to populate the nursing home field on the discharge abstract so they can create a database on discharges to nursing homes over the past few years, so that they'll actually, there's actually going to be a code for the nursing home, so they will know which nursing home the person was discharged to, which hasn't been collected consistently in the past. That concludes my presentation. If there are questions, I'd be happy to answer them.
Yeah, let me start off here. If we look at the takeaways, I don't actually disagree with any of the takeaways, but they're not tightly connected to the survey. They're more sort of observations about the industry, yes, which I agree with. So then I think the question is then when we look at the survey, we can kind of note there are some modest changes year over year, but no big red flags. It's just sort of more some interesting data variability. Given this assessment of the industry, do you feel like there's any modifications that are needed in the short-term survey or benchmarking so that we as a commission can start to, make sure that this part of the healthcare sector, which is going a lot of changes, we can perform our proper role about quality assurance. So.
Well, as Diane brought up, I wish we did have a benchmark, outside Maryland that we could look at to see, where we're going with this.
Meaning that you think that it would be a good priority to see if we can find one, yes, going forward?
Yes.
And that's one takeaway out of here?
Yes.
Okay. That's good. Other?
Yes, I'm curious. Do you have information on the demographic characteristics of the patient populations in these nursing homes?
In the nursing homes, yes.
So you have the information.
Yes.
Since the data is uniform across, we can assume that the demographics of the patient population does not affect what we're seeing here. Everybody's benefiting, correct?
Yeah. We actually, on the short stay survey, and I have not analyzed this degree, because it's an ARC survey, they do collect gender and racial and ethnic and age and education. So it will be interesting to look at that particular analysis for the respondents to this survey.
So I think that would be helpful, because it says that there's uniformity across the different racial ethnic groups being served. Or if we see variability, to what extent might it reflect differences in the patient population? So that's one question I have.
Mm-hmm.
The other is that you have a number of these in your small group of 30 that you dove into. 100% of them were nonprofit. Most were hospital system affiliated. But is information also collected on the characteristics of those systems? For example, how many of them are faith-based? We'd be run by the Catholic Archdiocese or other faith-based hospital systems. Do we know that?
We would have that information from our long-term care survey.
So it's actually in the data.
Yes. Well, not in the short stay survey data, but it's from the long-term care survey that we do every year for nursing homes. We collect that characteristic.
Do you think there's variability?
I don't know. I'd have to look at it.
Okay. That might be another, again, because of certain core values reflected in those systems? Yep.
I think it's a relatively small portion of the total number of nursing homes in Maryland that are faith-based. And I don't know how many of them would fall into this short stay participation group without looking at it. But it's a good point.
A couple thoughts. First of all, thanks, Carol. I thought it's really nice that you did this. I think it's another measure that when it's out there to the industry, they'll work to improve it, like in the past, the indicators that you've posted on the website, et cetera. Two thoughts. One is on the domain ratings. Just my, basic feeling, where the scores of, care and activity, et cetera, are lower in general, I think by about 5 or 10% from what the regular family survey shows. I don't think it's a factor as much of that the family does it versus the resident doing it, because I think those numbers are close. But these are people that are coming in for 3 weeks with a broken hip. They're not too happy to be there, and they're in a lot of pain. Basically, it used to be a hospital stay. So I think that's probably more of the reason that those scores are lower as compared to the long-term stay. Or the other message could be, if you're going to go to a nursing home, stay a long time, and you'll be happier. So it's one of those messages. The other thing, to Dr. Tanya's point, I think the industry, when they see these things, most short-stay units in these nursing homes pretty much look like the long-term units, and they blend into our overall satisfaction. When they see it's different in the short stay, I think, and I'm reminded of a presentation we had of, I think it was Holy Cross, had a senior-friendly ER. Was it Holy Cross Hospital? One of them. I think the industry will work harder to make these short stays happier, maybe more satisfied than as a long-term stays. So just a couple thoughts.
Thank you. Ben?
So, Carol, I wondered if you could, I know that our ability to access this data is somewhat limited, but before I ask you the question, I want to make the point that HSCRC originally asked us for this because they wanted to use it as a benchmark, one of the benchmark measures for judging their success under the new hospital payment model. So they're basically asking us to provide an aggregate number. But as the various initiatives have gone forward, there's been a lot of discussion about how hospitals are able to assess the quality of care provided at long-term care facilities, and does this type of information, we can make this information available in summary form at a facility level to hospitals who would be interested in judging what the quality performance is of various institutions that they might be considering contracting with. Is that correct?
Yes.
And so I think that there's more, as several of the commissioners have noted, the Healthcare Commission is only required to send sort of a number to HSCRC, but as time is, as the model is developing, we're seeing that this can be more valuable for decision-making on the part of hospitals, as well as, and certainly long-term care facilities as well. They should be paying attention to this because their competitors may be improving, and they may not be. To that end, the last question is, in your review of the data, are those averages you're seeing, are they reflective of the distribution of scores, or are we seeing some among the 79 on some of the domains? Are there some that are doing really well and then some that are doing lousy? I think that would be very helpful, maybe in a follow-up. Just note to the commissioners on, averages are good if you have a normal distribution, but if you're looking at a bunch of averages where you have a distribution that looks like someone fell on it, it doesn't really mean too much, that average number. So perhaps we can provide some insight on what the distributions look like.
Okay. Sure. And the ranges, just looking at the ranges of the aggregate scores, there don't seem to be any huge outliers.
Okay.
Dan?
Just a quick follow-up to that, making the information available. I realize it's short stay, so there may not be a lot of consumer or patient choice involved. However, nursing homes are one of the more shoppable services, and there's intense interest by the public in information about consumers and about nursing homes. And given that this is patient satisfaction, patient experience, consumer surveys, they're also very interested in that. In fact, often far more than the quality scores themselves. So if there is a way, if there is information shared on individual facilities, if there's a way to make that available to the public as well, that would be great.
This is on the Consumer Guide to Long-Term Care. The reports are available by facility, and you can
Great.
Find that. So
great. Thank you.
Any other questions? Thank you very much. Erin here? There she is. Erin Dorian, Chief of Government and Public Affairs, will present an update on legislative activities.
Thank you, Mr. Chairman and Commissioners. You have two documents in front of you. I'll be going through the presentation, but I also wanted to alert you to the second document. The presentation only has a couple of bills, which we'll talk about today. The second document is a table of all the bills we've been following this session, some of which we're not taking, staff is not recommending any position on, but we're going to keep an eye out and watch them. Okay, so to start, I just wanted to go through quickly what I'll be presenting. I'll be presenting on 4 bills. And 2 of them are self-referral bills. One of them we'll be asking you to take a position on, and that's the SB 320 HB 602, which asks for us to do a study of uterine fibroids. And then the first bill I'll be presenting on has already been heard in both houses, so I'll just go through that fairly quickly. So SB 92, HB 230, Health Insurance, Assignment of Benefits and Reimbursement of Non-Preferred Providers, repeal of the termination date, was heard in both the Senate and the House in the past 2 weeks. It actually passed the Senate on February 17th, which means it's crossed over to the House. The bill repeals the sunset date for the Assignment of Benefits laws. During the hearings in both the House and the Senate, the League of Life and Health Insurers offered an amendment to eliminate the 2-pronged payment approach. You remember you heard a report on the Assignment of Benefits law the last commission meeting, and there was a 2-pronged payment approach. The League and some of the other health insurers would like that 2-pronged approach done away with so that all of the carriers would be subject to the 140% of allowed charges test. The chair of both the HGO and Finance Committee asked that the League introduce this as its own standalone bill so they could push this bill through as introduced. That bill was, the standalone bill was introduced today. It's not on your list because it was introduced today. And the number for that bill is SB 803. So this is the bill the staff is going to recommend the Commission take some action on. It requires MHCC to conduct a study on the incidence of uterine fibroids by race, ethnicity, age, and county of residence. It also asks that we bring together a group of experts to talk about and include in our report types of treatments offered by physicians and the ability of these physicians to perform treatments less invasive than hysterectomy or myomectomy. And also they would like data on the number of women who undergo hysterectomy by race and ethnicity. MHCC staff estimated that this would cost approximately $50,000 to do the study, along with some staff time. We also would have to do this in conjunction with DHMH, and they believe that it would cost about a half an FTE of their own staff time to do this study. For these reasons, the staff is recommending that the Commission oppose this bill. It's not that it's not a very good and important issue to study. It's just we don't have the room in our budget to do this study this year. I'll talk a little bit about the budget later, but as you know, we're operating under a $12 million assessment cap. Our current appropriation is $14.6 million, so we just don't have any extra money to do anything new this year. We will make it through, but we really can't take anything else on. So I'll pause for a moment so we can ask a couple questions, and then maybe we can take a vote on this bill now before I move forward.
Any questions or comments for Aaron?
Aaron, is there I'm trying to figure out what the motivation is for this bill. Is there an epidemiologic concern or a cost concern or quality concern? I'm not familiar with the incidence or prevalence of uterine fibroids, but is it out of line in the state? Or the surgeries? That's what I'm trying to get what's the motivation for this to even be
considered? That's a very good question. We actually met with, Ben and I actually met with the sponsor on Monday. All the days are blending together. And there is a concern by the sponsor that in some instances, African American women and other minorities are not getting the least invasive treatment possible, or not getting treatment as soon as they need to get treatment in order to avoid hysterectomies or surgery. And so there is that concern. We haven't done any research to see where that concern is actually coming from. I mean, maybe Ben can expand on the conversation a little bit if he'd like.
So, thanks, Aaron. We did use our all-payer claim database to look at the incidence of hysterectomies, and what we discovered is that in 2013 we had about 48,000 women with uterine fibroid diagnoses. About 3,500 had hysterectomies performed. Another 4,000 to 5,000 had other surgical procedures performed. And we can, at that point, that was as far as our data can take us on the privately insured. Although we are making headway in getting privately insured private carriers to give us race and ethnicity data, it's not sufficient for 2013 for us to tell if there's any sort of bias in the distribution of those hysterectomies. We did talk to the sponsor, as Aaron mentioned, and suggested that she may also query Medicaid, and if they were not able to, we committed, although the staff doesn't know this, I committed to using some limited Medicaid data that we have to make that inquiry. I think that the point that Aaron emphasized most is it's not that we don't have any, we don't think this is an important issue, but our financial plight is very tight this year. This is but one of maybe 3 or 4 studies where we're going to have to reluctantly say we can't do this at this point.
So I think that if I look at my own family, it's a big problem, and I would take you all out to dinner if we don't see huge racial ethnic disparities in this issue. So 2 tiers. How do we say no because of budget issues and not also send the message unintendedly that it's not important? And that's what I want to make sure that, given the disproportionate burden of this issue, I want to make sure that we don't send the wrong message. So if there are other very important things that we're not going to be able to do because of finances, then let's raise that flag real high right now. And not just on this one. Because I don't know, who's the sponsor?
So the sponsor in the Senate is Senator Nathan Pulliam, and the sponsor in the House is Delegate Glenn.
Well, they have loud voices. And I don't want to send an unintended message. This is a big issue, and I think the data will bear it out.
So I think you make a good point about how to send the proper balance of the message. And so if I just kind of reflect on the situation, I think what we're hearing from staff is, we have a situation today in which there's a fiscal cap. The realities of where we're at with the government is it's not likely to get increased for us, so that there's a cap on investment. And yet there's a set of things in the data that if we could get it, improvement in the data and privately insured, trying to get some of this other those data elements, doing this becomes actually relatively low cost and quick to do. So that's, I think, maybe I'm just brainstorming here. Maybe one aspect is actually trying to have this as being a little bit of an education around the infrastructure needs, and communicating that those infrastructure needs could answer a lot of questions around that if we could get to it. And I think that's really the challenge, because you're saying I can get part of the data, but I can't get all the data very quickly because we don't have the infrastructure. So that's actually what a lot of the costs will go to.
And I think that one of the other points is that getting the data is really just the first step. It's convening basically clinical panels, developing some staff expertise to make an assessment on the weight of that expertise. So that's where the real cost is, I think. I think the statements that we made to the sponsor were absolutely in line with what you said, that this is, we think this is important, but we don't know how we can do it this year. We will give you the data that we have to feel free to carry this forward. By accident, we were waiting for to speak with the senator immediately before a senior representative from the University of Maryland at Baltimore was there as well. We were trying to enlist his aid in the study. I'm not sure we were successful yet, but we did suggest that perhaps this was a study better undertaken by the School of Medicine, because in terms of the scope of interventions that might be considered, we certainly would have to go to them in any case. That the data is, we'd like to have it more accessible and the race and ethnicity data complete. But the real cost is the convening of the clinical panel.
Yeah. So, Diane.
So I think
Ben and Craig, this is Kenny here.
Sure.
I have a question. I understand where Stephen is coming from, and health disparities is a important issue to me. But I'm actually curious, how concerned are we that if we were to approve this could quote unquote open a Pandora's box of getting similar other requests like this?
So I think that the box is already open. So I think that we get requests like this because we have been very good in the past in doing things. I think that I just think the box it's open. So I don't think we need to worry about that aspect of of approving of doing this study or not doing this study.
Okay. Thanks, Aaron. Go back to Diane.
So there's when, I guess I'd like to understand a little more, when the Commission takes a position on a piece of legislation, is there a formal written position that is created and submitted?
Sure. So we can do a couple of things on bills. We can take no position. we can, staff writes letters of information on bills, and most of the time we don't even bring those to the commission. We just write the information that we already have, or our knowledge of what the commission has studied in the past. We can oppose, or we can support, with amendment. For everything, there's always a piece of written testimony. In the case of a position like oppose or support with amendment, we write what's called a position paper. And then along with that, then usually, or if appropriate, the Senate director where the bill would fall under comes down to Annapolis and presents oral testimony as well. So
that's very helpful. If I imagine that the concern about the fiscal note is not specific to this topic.
No.
So if the Pandora's box is open and these requests will come along, this may be this was likely the first and perhaps other issues that might come to us where the response might be recommended to have concerns primarily driven or solely driven by the fiscal note. It seems that there may be an opportunity to make it very clear in the written statement that this is an important issue, that here's the data we have available, here's how we can work on this issue within the constraints of our budget, particularly with partners, because we do want to see an understanding of this issue. And that could end up being, in some ways, not boilerplate, but it could end up being an approach that's taken on other issues that might come along. I will say I have 4 sisters, and of the 5 girls in my family, 4 of us have fibroids, uterine fibroids, and 3 of the 4 of us, myself being the only one who did not, 3 were, as I say, talked into having hysterectomies at a young age, and it is it's a huge shift. It's a huge shift in lifestyle and all kinds of things, and I pushed hard not to have the invasive procedure, and but I'm much more savvy in terms of standing up for myself. So personally, I think it's very important to make it clear that this is a big deal.
Okay. Michael and Diane, and then Dr. Thomas.
Mr. Chairman,
Hey,
Commissioner Khan here.
Yeah, Kenny, can you just hold on one second? I just want to.
Sorry.
There's a lot of. I want to sequence you. You'll be number 4 in line.
Okay.
All right.
Sorry. Hi, it's Michael speaking. First of all, I mean, thank you for pointing out how important this issue is, and it, and health disparities. And it took me like 3 minutes to find some statistics national about the health disparity issue here. So my question is not that I'm trying to suggest whether there's a way to take this and frame it a little differently, actually make it somewhat larger. And my question is this an opportunity for us to really kind of, as the commission, say, health disparities is a big issue? Here's an example. And instead of doing a study which, at least on the face of the way it's described, would pretty much prove what we already know, kind of really think through what a good study would look like in terms of health disparity issues. This is an example. Make that the work. And you wouldn't have to spend as much money, but articulate what a project like this would look like and how we could start addressing health disparities. This is a good example. I just toss it as an opportunity to not send the wrong signal, send actually a bigger signal, maybe defer the actual study, but really articulate what it is we'd like to see happen in terms of the health disparity research in Maryland.
Before we move on to the next statement, Aaron, would you want to have any comment around that kind of dialogue can happen productively or not?
I'm trying to think about what the best way to move forward with that. I think there is a dialogue happening in the state around health disparities. I know there is a dialogue happening in the state around health disparities. In fact, in my mind, and this is my opinion, not the opinion of anybody else on staff, in my mind there are almost too many disparate discussions happening. So I think that there is a need for the state to have one voice, so to speak. Not that you can have one voice on such a big issue. So there is room there for leadership to happen around this issue. I'm just not, I don't know what the right leader, who the right person, where the right leadership would be. Maybe Ben could add a little bit, and again, that was my opinion, nobody else's.
So in the previous administration, the Office of Minority Health had a very prominent position, and I think the sponsor did mention that at least she thought or was aware of their budget woes, so she had came directly to us. But I think the idea of having a broader discussion, given a new administration is now in place, of who's doing what is appropriate. I think that Senator Nathan Pulliam, who is very supportive of commission initiatives in the past, would be willing to participate in that. I think the idea of agreeing for MHCC, agreeing to take this on without considering our sister organizations who have as their single role health disparities might not necessarily be seen. It might be seen as overreach on our part. So I would want to do that in consultation with those, in terms of, as we have when Dr. Hussain was leading that group, to make certain that we're all working together and not doing something that is viewed as going it alone. So I think the idea is a good one. Mm-hmm. And they do have a acting executive director, but I think we would find that perhaps something we want to revisit in terms of roles. I think the second thing that we can continue to do at a very low cost is remind the senator that we can, over the next year, as the Medicaid data becomes more accessible, that which does have race and ethnicity information on it, that we can do some additional monitoring to keep this issue in the forefront going forward, as we would hopefully have a cap increase in 2017.
Catherine and Dr. Thomas.
I go back to the complexity of this. I think it's very important, and Ben, I think you mentioned it, that the evidence for some of the new technologies for this intervention, as well as what we already know in this state on disparities, when finances are tight, I think you have to choose between what's the most difficult. And I don't propose that the MHCC is the only forum to weigh in on which of all the disparities that we're addressing should we put all of our eggs in one basket. The other point that I make is that I think this is a rapidly changing area, and without the School of Medicine or an appropriate analysis of what the evidence is, I think we risk being responsive without a particularly positive gain in the medical community with the translation of some of the new technologies. And I do think that is the leadership that should be combined with what you said.
Well, I don't know to what extent senators seek guidance when they put these things together, but had this come to us with the allocation from the state of $150,000, would we say no if it came with money in the legislation? See what I'm saying?
Yeah,
so if we say no, I want to say no for something other than the money, because if it came with money, would we say no? And I always have those on separate tracks. Now, if this is going to be an issue, I think the bigger issue is there are actual consequences when you put caps on our agencies. And this is not the only thing we're not going to be able to do. This is what's in front of us right now. It's maybe a broader communication issue. But we should not be silent on all that we will not be able to do because of the current situation. And this is just one senator who needs to echo that more broadly. But there's a certain quality that comes from the work of this organization that should not be jeopardized in the name of, let's see what we can put together in a reduced fiscal environment. If we don't have the resources to do it with excellence, we don't do it. But they need to know that that's not the only thing we're not going to be able to do.
Aaron, can you just educate us on the standard practice around attaching dollars to these things. Not.
So
you educated me about a week ago. So.
So, I mean, it's a little bit, it's half science and half art. It depends, you know, Ben and Bridget and I look at the scope of the study. We look at, we try to estimate the amount of staff time.
No, I meant whether these bills get passed with money in it or not,
okay.
versus just saying, do it on your budget.
Yeah. So in Maryland, we have a very executive-driven budget. The General Assembly. Now, if most of you might know this, so I'm sorry if I'm repeating it, but the General Assembly can only reduce funds in the budget once it's introduced by the governor. They cannot add any funds to the budget. So the budget for, we're in calendar year 2015. We're in the middle of fiscal year 2015. The budget that is in front of the General Assembly now is fiscal year 2016, which will start on July 1, 2015. I know that was just a lot of numbers and dates, but the General Assembly is looking at the budget for fiscal year 2016 right now. Anything that they pass in this General Assembly session they could not include money in the fiscal year 2016 budget for it because they don't have the power to add to the budget. They can only cut from the budget. Now, that said, there are times when money is added to the budget by the governor in the middle of session. That happens for executive priorities, but it does not normally happen for legislative priorities.
Okay, thank you. I just want to keep going in order. Commissioner Khan, you are on the phone.
Yes, thank you, Chairman Tanio. My question is that, you know, health disparities is an important cause to me. I fully understand the budget constraint. So instead of proposing that we oppose this bill, could we perhaps support with amendment, and the amendment being that, you know, we'd be happy to work with a consultant designated by X agency, you know, to be paid for by the agency, and where we will only just provide the data. I'm just thinking out of the box here.
Which agency would be paying for this? I was just trying to track.
That's a great question. So
okay. All right.
We have two fine healthcare institutions here, and they do a lot on this health disparity. So I just was wondering, again, thinking out of the box, if that could even be plausible or it's just unrealistic.
Okay, thank you. Other comments or questions here? I know from this side. No. Let me just synthesize what I've heard from folks, and then maybe even suggest a potential motion. I mean, I think there's some themes out of the room, which is we absolutely should not lower the importance of this particular issue, but rather actually there's potential to frame it broader about disparities and attacking that holistically. While there's a fiscal reality around of what the cap is doing, there's a chance to actually educate people around the kind of resources that are needed, and that, in fact, there's not as much resources as we think is needed to really start to address some of these analytics more effectively. And then there's probably a different sort of coalition building, if you will, that's outside of any position. So in the past, staff has worked pretty well when this commission gives some general guidelines as opposed to a complex motion, and then kind of puts together a position that we kind of review in a couple of days and just, you know, can give specific edits. So I'd love to kind of go in that direction. I'm just curious if anybody would want to sort of say a motion that staff would put together a position paper that said we're gonna turn this, we're gonna be against it because first and foremost the fiscal piece, but there's an education piece attached to it. But that we also make quite clear our thoughts around disparities in this particular issue, and just let staff kind of work through some of that. I mean, but I'm not putting a motion out there, so I'm just letting somebody
You put it out there, I'll second it. It's on the
Yeah.
table. I think you have a good alternative.
Okay. Any discussion of the motion? Diane, you're
Yeah, can we separate the general statement? I mean, maybe there's a white paper that's needed that applies generally to the fiscal issues, and that then the separate from that would be the position on this bill, which would reference that that position about the fiscal situation, because it is overarching. It is an overarching issue. It's not unique to this bill. The other piece I would, even though we know disparities is likely what would be found in this kind of study, there's also the issue around this particular issue by itself, as far as more invasive procedure that patients are subject to. It's more expensive. So there are a number of issues beyond the disparities issue. So while I agree with Dr. Barr's suggestion about a broader position around disparities, that also is, it shouldn't undermine the importance of this particular issue as well.
Yeah. So Ben, what I never want to have is the commission sort of give staff some mandate that's not practical. So any thoughts?
Well, I think that in terms of the commission's cap, that situation is well known, and I don't think we want to emphasize that too much more. That the commitments we've had is we will resolve that next year. So I think, other than that I don't think it would be helpful for the commission to continually echo that on every occasion. It has been heard and said, in due time, which may not, necessarily be beneficial to this bill, but I'm confident will be addressed. But I think we can wrap that into this in a way that the commissioners would find acceptable, and make the point to the sponsor that we're not walking away from this issue or disparities, certainly broadly anyway.
Other comments or questions? If not, just to synthesize, I think there's a motion on a table to put together a position paper that staff would put together, and we would review afterwards and give feedback on. That says we're opposed to this on the fiscal pieces, offers some education, but to Ben's point, may not be too much, given that the legislature is educated on that, and then frames the particular issue that it's not because of this issue not being important. I might not have been as clear on that as I should have been, but people understand what we're voting on? I see the collective nod.
Yes, I've been taking notes, so I'll be working feverishly over the weekend to get this paper.
Fair enough.
Just before, just so we're all clear, when's the bill hearing on this?
So in the Senate, it is the 25th, which is next. Yeah. And then in the House, it's the 26th, so next Wednesday and Thursday.
All in favor? Aye. 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 Any opposed or abstentions? Okay. Erin, keep going.
Thank you. So the next two bills I'm going to go through together, and then we're going to discuss. I'll go through both of them, and then maybe we can have some discussion on the two bills. We're not asking you to take positions on them right now. We likely will in the future. We're just putting the issues out there and letting it marinate for a little bit before we actually take a position. These are both self-referral bills. If you remember, we did a study on MRI self-referral over the summer, and you heard it in December. So SB 539, HB 944, they are allows oncology group practices to self-refer for radiation therapy services or non-diagnostic CT scan services. And it requires a for-profit oncology group practice to report to the
to DHMH the number of Medicare, Medicaid, and CHIP patients served. So it's a fairly simple bill, but it would allow oncologists to self-refer for radiation treatment. The next bill is one that I'm sure a lot of us were expecting. It's Health Occupations MRI services and computer tomography scan services, patient referrals. It permits self-referral for MRI or CT under certain conditions. It needs to be furnished by an individual employed and directly supervised by the referring practitioner. It needs to be provided in the same building, billed by the group practice which the practitioner is a member. The self-referring entity must register with the Maryland Healthcare Commission within 30 days of self-referral, and it also requires MHCC to repeat the MRI study with the pre- and post periods being 2014 and then the 2016-2017 period. So this one has a little bit more of an impact on us, and again, we come back to that funding issue, which we will bring up for this particular bill. But we're not asking for any position right now. We just wanted you guys to talk about them. Or just think about them.
Any comments? Yeah.
Unless my memory is wrong, I think when we had the presentation a couple months ago, it really shows there wasn't any dramatic differences with self-referrals versus sending to someone, physician in the offices sending to someone else. They were just using the appropriate guidelines for the order. So I don't see it as being an issue.
Well, it's interesting because that was exactly my point at the time, was that what it showed is that physicians had certain patterns at the time due to the ownership that didn't decay as much as people thought. And so they were kind of locked into that pattern. So, and the study couldn't really show anything else besides that. And I was very worried that people would run away with that broader headline. So that's in essence a little, people are running with the broader headline.
I should have turned. Can I just mention one other thing? I have notes here, but I didn't turn my page as I was moving forward. Just to remind you all what you said in the letter that we sent along with the MRI study. The commission outlined 3 conditions under which self-referral may be acceptable, and the 3 conditions are the practice would enter into a risk-based financial arrangement, such as gain sharing or shared savings. The practice must demonstrate sufficient scale to have these gain sharing these financial arrangements make some sense.
And the equipment.
And the equipment needs to be used, and that the practice commits to ongoing reporting. Now, neither of these bills have any of those stipulations attached to them.
Would we ever give technical advice here? Because, I mean, so when I see that we're required to repeat the MRI study, I would, if I had my way, I'd be saying, well, if you really want to understand the question, you might want to look at appropriateness of people who had the MRI and compare it to people who didn't. And it wouldn't be a claim study. It would be actually kind of looking at the particular decision making. Because the whole structure of the study just doesn't get to the essence, which is on the margin are people ordering more tests than not due to just being influenced by the presence of an easy machine down the hall.
Yeah.
There's no way to answer it through the way that we structured it. Is that possible to give that type of
I mean, I think so. I think we can. I think the idea is that any sort of encouragement to the bill as amendments can be added and stricken does pose some risk, and the Commission would need to be very confident and have commitment from sponsors that they were willing to live with this.
Put it this way, at the right time, if it looked like that bill was sort of going to happen. Yeah.
Yes, and Aaron, if you can sort of outline where we think the different interest groups will line up on this, it's probably helpful to that hospitals are adamantly opposed to this and will be arguing that it compromises the new hospital payment model. Of course, some specialties will be for this orthopedics, radiation oncology, radiology generally will oppose the orthopedics bill, but may favor their own bill. It's quite complex. But I think, the bottom line is that the reverse, the loss of equipment did show that utilization levels in practices that had it remained higher than those in practices that referred out. And that's something that I think we probably should keep in mind. It also is consistent with the literature on what happens when equipment is acquired. It's very strong that you see a surge in utilization, sort of like the sports car. You now can drive it around the street, because you have it, and there are all sorts of forces in healthcare. You want to do the best for your patient. You have to worry about liability. It is an additional opportunity to bill. All of those factors come into play when acquisition of equipment comes into place. The strong evidence I see is that some of these sort of anecdotal studies that have been done that show that practices that own equipment do have higher results of unremarkable imaging, which does suggest that it's probably going to be because you have it for whatever reason, and I don't necessarily fully subscribe to it's just you can make money, but you have it, that you do tend to use it more frequently. So I think, we really want to be cautious here. If we could impose those 3 conditions, I think that it would be at least worth considering, but I don't think any sponsor is going to agree to that because operationally there are no risk-sharing arrangements currently in place other than with Medicare, so they would be agreeing to something that couldn't occur for the time being.
Other comments, discussion? On the phone, Commissioner Khan, Dr. Peralta? Okay.
So just from a timing perspective, these bills are not being heard. The oncology bill is going to be heard in the Senate in the first week in March, but they're not being heard in the House until March 16th for both of them. So we have a little bit of time to think about it and see, again, where the other interest groups line up, and before we run off and take a position.
Okay.
So I'm not going to go over this very much because we've talked about it a lot. We had both of our budget hearings this week. They went very well. We have a $14.6 million appropriation. As we talked about before, we have a $12 million assessment cap. We do have money in reserves, which we will use to make up that disparity. The DLS analysts recommended that the legislature concur with the governor's allowance, which is good, and then the budget decisions will begin the first week in March. I also just wanted to let you all know that the staff, especially Ben and our center directors and our chiefs and everybody, have been working really hard. We did 4 briefings in 1 day in HGO. Ben spent a long time on the witness stand, and I think that everything that we presented was met with a lot of positivity. We presented our new quality website, and that went really well. And so I just wanted to thank the staff for working so hard and just sort of bearing with us as this 90-day session rolls on. So that's all I have. If there's any questions.
I apologize. May I go back for 1 second to the radiation therapy services? There doesn't seem to be as opposed to the MRI one, where at least there's some opportunity, or MRI CT scan one, sort of to monitor. There's no monitoring provision on the radiation therapy services, correct?
Except for the nonprofit oncology group practices having to report to DHMH, there is no other monitoring.
Well, it says for-profit ones.
Oh, I'm sorry, for-profit. That's what I meant.
But that's just the number of patients seen in those insurance categories. It doesn't really track the pattern of referrals or utilization or practice guideline following. any of those things. So I would just raise it as another concern in addition to the ones that have been raised.
Terrific.
Thank you
Thanks,
very
Erin.
much.
Thanks for a great job. All right. Eileen. There she is. Eileen Fleck, Chief of Acute Care Policy and Planning, and Paul Parker, Director of the Center for Healthcare Facilities Planning and Development, are going to present an update on the most recent utilization forecast for cardiac surgery.
Good afternoon, Mr. Chair and Commissioners. So on this slide, you see the cardiac surgery utilization projection for calendar year 2014 through 2019. It was published in the Maryland Register on February 6th of 2015. So this is the projection that will be used in certificate of need reviews when an applicant is seeking to establish or relocate cardiac surgery services. An applicant must demonstrate the need for the program and the ability of the program to meet the minimum target volume of 200 cases. An applicant must also demonstrate that its volume projections and an assessment of the impact on existing programs is consistent with the utilization projection, or alternatively, it needs to demonstrate why the utilization projection is an unreasonable basis for forecasting case volume. And so after I speak to you more about the projections, Paul will talk about the upcoming certificate of need reviews for proposed cardiac surgery programs. So as you can see in this table, the projected number of cases in all regions is going down from 2014 to 2019. And that's because, hold on. As I've shown you on this slide, there is a downward trend in cardiac surgery. It was increasing until maybe about 2002, and then it started to decline. And I've also shown you, the PCI cases just for reference where there's been like a sharp increase, and then that's also gone down. So the utilization projection is based on the most recent 6 years of data, and it essentially assumes that the previous trend in case volume will hold in the future for various subgroups defined by age and location of residence, with adjustments for migration and changes in the population. And so on the next few slides, I have the case volume for individual hospitals for each of the regions. And so on this slide, I've shown the hospitals that are in the Baltimore Upper Shore region and the volume in 2009, 2013.
Can you go back?
Sure.
So if you plotted, let's just say, like the PCI against national trends wouldn't sort of have been as acute, right? There was a very Maryland-specific drop in PCI, or is that parallel what's happened nationally?
I haven't looked at that recently, so I'm actually not sure. I think the handout that I gave you had, some markers on here in terms of like the Seaport study, and so I think because we were participating in that could have influenced our trend, and for that reason it may look different than the national trend.
Yeah. Yeah, I guess I was just wondering whether, the public events around PCI and near that peak actually led to a different Maryland trend than any other state. I understood that.
I think a couple of things.
Go down as steep?
A couple of things happened around that same period. Not only did we have, obviously some notorious publicity about appropriate use of PCI in Maryland that may have affected certainly the direction those trends took. But at the same time, we also had the development by the American College of Cardiology and SCAI of more guidance on appropriate indications for PCI. And I don't think there's any question that practitioners across the country really began, with those guidelines, began to take a more serious approach, and I think the institutions as well, a more serious approach to really looking at appropriate use and doing a much more rigorous job of trying to document appropriate use in these cases. And so I think, not only in Maryland, but across the board, those had a strong influence on decreasing the number of PCIs that were occurring.
Yeah, it's just remarkable to see such a quick trend on both sides. You don't usually see that. Keep going, sorry.
Oh, that's fine. So as I was saying, on this slide, it's the Baltimore Upper Shore region and the hospitals within that region. And I have the volume back in 2009, the volume for 2013, and then an annualized number of 2014 cases, which is based on the first 3 quarters of 2014 data for the Maryland discharge abstract. And then I have the 2014 forecast. So what you see is that, based on the annualized numbers, the regional total is about 3,500, but the forecast is only about 3,000. So it is somewhat lower in the forecast compared to what it looks like it would probably be just based on annualizing the 3 quarters. So we'll probably see how that turns out in the next couple months. It is different in different regions. So in the metropolitan Washington region, because I don't have the 2014 DC data, I can't come up with an annualized number. But if you look at just 2013 compared to 2014, the forecast, it's actually a very similar number of cases, about 2,100 cases total. And then in the Lower Eastern Shore region, it's actually very close in terms of the annualized number of 2014 cases and the 2014 forecast. It's a difference of less than 10 cases. The Western region, where we have just 1 hospital, there has been a significant decline from 2009 to 2013, and the annualized number of cases is a little bit higher than the 2014 forecast, which seems quite low if you consider the percentage drop from, say, 2009 to the 2014 forecast. So I'm not really sure what the reasons are behind that. It could just be that patients are migrating and going to hospitals in other regions, or maybe going outside the state for surgery. So that's really all I have. If you want to ask questions at this point, it's fine. Otherwise, I'll turn it over to Paul.
So just briefly, some of you may be recalling our activity of last year and the process that we went through to develop a new state health plan for cardiac surgery. And as you'll probably recall, one of the emphases, not only in the legislation, but basically in our whole rethinking of how to regulate this service and also regulate PCI as well. And certainly the direction that we got from our clinical advisory group, and I think this direction is really reflected in our plan, is that there is an emphasis in our new regulatory scheme on performance, and much less emphasis than we've had historically on numbers. So you might be saying, why are we sitting here having a presentation about numbers on cardiac surgery? I think it's because we thought it was important to kind of let you look at and become aware of the trends that we've seen in cardiac surgery and how that affects our forecast model. This is a methodology, a forecasting methodology, that in many respects is similar to what we had in the old plan prior to the new plan that was adopted last year. We did decide to change the regions that we used as a basis for forecasting so that they better aligned with the actual catchment areas of the cardiac surgery programs that we have in the state. That caused a little bit of consternation among certain hospitals who have plans of various kinds. But we thought that actually made sense in terms of providing these hospitals with the best kind of foundation for addressing the trends when they come to the commission to ask for things. And want to emphasize that the plan really does make this forecast to some extent a secondary factor in the review. If you look at the way our new plan is constructed, someone who's coming in to the commission and saying, I want to establish a new cardiac surgery program, or I want to relocate an existing program, is really asked to provide us with 3 points of reference. And the first is actually a service area analysis. So that is the most important factor. We want to look at the actual service area of the hospital, what sort of demand for cardiac surgery is occurring within that service area, and what is the capability of the hospital to actually establish a new program, or if it's moving, kind of reestablish in a new location a cardiac surgery program within that service area, and what sort of market share can it achieve. We have a similar numerical target for new programs. We have the same numerical target as we had in the old plan, which is we want them to achieve a minimum case volume of 200 cases per year. And as you can see, we're not in too bad a shape in terms of our existing program volumes. We have our newest program in Montgomery County Suburban that really hasn't been able to kind of go much above that volume. It's complied with that target, but it's been pretty close to 200 or slightly over 200 cases for most of its existence. We have a program that has failed to operate at those levels for a long time in Prince George's County, and that is one of the cardiac surgery programs that's currently under review for relocation along with the hospital. And then we have a recent development in Western Maryland where that program, which clearly provides access in a dramatic way for the Western Maryland population for this service, that's quite different from what we see in urban and suburban areas. They recently dropped below our target volume of 200. And just to emphasize the difference in the new plan under which we're operating, unlike the old plan, that doesn't create a great sense of alarm for us. Under the new plan, and this is based on recent research that's been done in the period of time since our last plan was actually developed. There is certainly evidence that hospitals can function with case volumes below 200 and still provide good quality of care. So our new plan really incorporates the idea that we'll be monitoring what's going on at a hospital like Western Maryland Regional, where we're dropping below our target volume. And if we see that there are quality issues arising, we'll have a focused review to take a look at that. And if we don't see indicators of possible problems or issues there, like every other hospital, they'll be subject to a periodic formal reevaluation of where they stand in terms of meeting our performance standards and what is the actual implication of that drop in volume from the standpoint of both performance and perhaps economics of the program. And access, of course, will be an important issue that we consider. So as Eileen mentioned, this is a bit of foreshadowing because we do have 2 letters of intent that have been filed in Maryland to establish new cardiac surgery programs. Both are from the hospitals of Anne Arundel County, Anne Arundel Medical Center, and the University of Maryland, Baltimore-Washington Medical Center. So we do anticipate getting applications filed very shortly for those 2. And as I've mentioned, this new forecast that we recently published will be something that both of these hospitals have to address in their applications. Both are in that Baltimore Upper Shore region. Can you go back to that? And so actually, why don't you first go back to the graph. So as you can see at the very tail there of our red line, the cardiac surgery volume line, we do see that decline in volume has flattened out over the last couple of years, and there's even a little bit of an increase. So we may be seeing an inflection point. It's a little early to tell for sure, but we may actually be seeing, at least for some period of time, a stabilization of that trend in cardiac surgery volume. And then if we look at
So Paul, on that, can I ask, if you go to that graph, if you put demographics and the population aside, what's the core assumption about the change in the practice of medicine for the next 5 years? Is it that it didn't change, or did it change the rate of the last 5 years or the last year? That seems to be the critical piece in the forecast.
Well, if you're asking me to interpret.
No, I'm just asking what's in the forecast. So in the plan, there had to be a basic assumption about what's likely to happen with the practice of cardiac surgery. Is it going to be like it was the last couple of years, or is it going to go down, or is it going to go up? So it's just
the assumption, the primary assumption in the forecast is that the recent past is a predictor for the future.
Recent meaning 11
The last
and
6
12?
years.
The last 6 years.
6 years.
So you take an average of the last 6 years.
Right.
Okay.
The average change year to year, the average of the change from year to year.
Along-
my calculus.
Along those lines, and on that, especially relating to that graph, have you seen or did you collect any information on cardiac deaths in that same time period? Was there an increase in cardiac deaths in the street, in the ER, with the drop in stents by whatever that percent is? Has it affected consumers?
I don't think we've seen dramatic changes in heart disease as a cause of mortality in recent years. Long term, there has been a decline in heart disease as a cause of death, and there's been, a lot of speculation on exactly why that's occurring. Are we actually listening to our doctors? Are we living healthier lifestyles, or is it actually really a function of salvaging people who develop severe heart disease and using these treatment modalities to extend their lives? And from the heads moving around the table, there seems to be a consensus in the group that it's probably more of the latter. But if we can move to the Baltimore region. So that recent change we've seen in the trend for cardiac surgery is clearly evident here. We had a fairly steep decline, and that's why our forecast, the 2014 forecast, the last column there, shows that we're projecting dropping from around 3,250 in 2013, an observed number, to 3,000, a little over 3,000 in 2014, and we're continuing to go down through 2019. We're actually predicting a decline to around just over 2,600 by 2019. But then if you actually look at what's happened in 2014, so if you can go back again, this is the region where we've really, this is the region that's really created that little fillip that we saw on the graph. We've had kind of a return of volume really across the board. Clearly the most dramatic turnaround is University of Maryland St. Joseph, which is clearly a program that suffered because of PCI and the problems with PCI. That's now been acquired by the University of Maryland and incorporated in their system, and they're making a big effort to kind of reestablish the cardiac services specialty at that center. But across the board here, you see some pretty good numbers through the first 3 quarters of 2014, and that's why on an annualized basis, when you look at those numbers, this is where we see a fairly healthy gap between where we might be in 2014 versus our forecast. Again, it's early days, but again, this is the region where the residents of Anne Arundel County obtain cardiac surgery now. Anne Arundel County is kind of interesting. It's a little split. A majority of the residents of Anne Arundel County who obtain cardiac surgery do migrate to the Baltimore area for this procedure. But a fairly healthy minority also go to Washington, D.C. for the service. And when you look at geographically how those areas relate, as you can imagine, it tends to be northern Anne Arundel County, which is suburban Baltimore, versus Annapolis, where we see greater numbers of people migrating to Washington, D.C. for this service. But we will be reviewing cardiac surgery applications this year. It'll be the first time in a long time that we've looked at a new cardiac surgery program. Our old plan really provided very limited opportunities for the commission to do that, and we in the new plan, I think we adopted kind of the general approach that we've taken in the last few years in terms of redeveloping our state health plan, that we did want to not close out opportunities for the Commission to consider changes in the landscape of services, but to actually develop standards that allowed entry into this process, the regulatory process, but with a set of standards that allows us to make, hopefully good decisions. So with that, I'll close, and we'll take any questions you have.
Questions or comments?
Just a quick comment. I might take issue with what you said about the rates dropping because of us learning how to salvage better. I think that's true, but I would take issue with that and say that certainly smoking rates have gone down, for example, from 30% in Maryland probably in the early 90s to now below 15.
Right.
So that has certainly had an impact on this as well, I'm sure.
And if we could have some success with obesity, we'd probably really be in good shape.
Okay. So to speak.
And that wasn't directed at you personally.
We'll strike that. We'll strike that for the minute. Okay. Any other comments or questions? All right. Thanks for the foreshadowing.
Thank you.
Linda Cole and Carol Christmeyer are now going to present staff's ideas for a new conceptual approach to planning and regulatory oversight of home health agency services in Maryland.
Good afternoon, Mr. Chairman, Commissioners. This is a joint project worked on collaboratively by our two centers. I will present an overview of our approach to health planning for home health agency services, and then Carol will present quality measures, which are a major focus of this new approach. Kathy Weiss, who's the author of the white paper and chairperson of the Home Health Advisory Group, was not available to present today. As you know, the Commission regulates many types of healthcare facilities. Although it is not a physical facility, according to our statute, a licensed home health agency is defined as a healthcare facility and covered under a certificate of need. There are a few different types of home care providers separately licensed in Maryland, which include residential service agencies, RSAs, and nurse referral service agencies. Only Medicare-certified home health agencies are covered under CON, so that is the focus of our planning efforts. Staff is in the process of updating the home health agency chapter of the state health plan. An initial step was to develop a white paper as a background piece, and you received this in your mailing. This includes information on the supply and distribution of home health agencies, trends in utilization and financing, quality assurance measures, issues regarding the current regulatory approach, and a conceptual framework for a new approach. We have also convened a home health advisory group, and you received the membership roster for that group. The charge of this advisory group is to assist staff in reality testing of our concepts and identifying factors contributing to the changes in utilization, addressing state and federal regulations which impact home health, reviewing the use of quality and performance measures, and reviewing the suggested new conceptual approach. In this group, we are working with the industry in order to give work group members the opportunity to present ideas and new approaches. Participants in the advisory group include home health agencies of various size, geographic location, and types, as nominated by the Maryland National Capital Home Care Association. We also have an RSA representative, consumer representative, licensing, CMS, and the Office of Healthcare Quality. We have had one initial meeting and anticipate about 2 more meetings. To provide some basic background, there are 56 licensed home health agencies in Maryland. 50 are general and 6 specialty with limited authority to serve a special population group. The agency type is shown here. Most are freestanding, and 63% are for-profit. Most home health agencies are located in the metropolitan areas of Baltimore, as well as Montgomery, Prince George's, Carroll, and Frederick counties. The vast majority are authorized to serve more than one jurisdiction. However, not all home health agencies serve all of their authorized jurisdictions. For example, while 9 agencies, or 18%, have the authority to serve 11 or more jurisdictions, only 5 agencies, or 10%, actually served at least one client in 11 or more jurisdictions. This slide provides data on the typical or average home health agency client, and this is based on 2013 data from our annual Maryland Home Health Agency survey. 70% are 65 and over, and 60% are female. By race, 59% are white, 22% African American, and 2% Hispanic. Most were referred from hospitals, and most were discharged with their goals met. The principal payer is Medicare for 72% of clients, followed by private insurance for 18%, Medicaid 5%, and HMO 4%. Just to briefly review some trends from 2004 to 2013, there has been an overall increase of 21% in admissions, which is the blue line. At the same time, the number of home health agencies, shown in the red line, has been relatively stable. Therefore, statewide, the average number of admissions per agency has grown. The capacity of agencies vary based on the number of jurisdictions that they're serving and based on their staffing. In terms of the number of agencies, it has not been a static picture. There was a certificate of need approval of 6 additional new agencies in 3 jurisdictions during 2008 and 2009, plus CON approval for a specialty agency to serve pediatric clients. The decline in agencies from 2012 to 2013 was based on 2 agencies which were acquired by an existing home health agency and were eventually closed. The number of agencies thus declined from 58 to 56, but the number of admissions in that time period stayed about the same. Also from 2004 to 2013, home health agency clients, shown by the blue line, increased by 16%, and visits, as indicated by the red line, increased by 36%. What we see here is an overall increase in utilization with an increasing average number of visits per client. The slide shows a decline in use between 2004 and 2007, and then an increase from 2007 to 13. This may be due to a combination of factors, including changes in Medicare's prospective payment system and reimbursement policies, new CMS requirements for physicians' documentation of a client's eligibility for service, and implementation of the ACA in 2013. The white paper also discusses some of the issues or challenges with the current regulatory approach for home health agencies. For the last plan chapter update, we used a conventional approach and the data that was available at the time. In terms of the need projection methodology, the current chapter relies on statewide assumptions about client referral from hospitals and other sources. It assumes that the number of clients will change consistent with the population changes, with fixed assumptions from the base year to the target year. The output is a projected number of clients, not agencies, and it uses a standard statewide volume threshold for all jurisdictions. In terms of quality measures, there is not much stated in the current plan because quality measures for home health agencies were not well developed at that time. It requires the presence of a quality assurance program. The new conceptual approach, which is still conceptual since we're just beginning to discuss this with the industry, includes a shift towards greater emphasis on quality and performance measures. This shift away from forecasting need based on utilization and the quantity of home health agency services, as in the past, and towards greater emphasis on quality and performance measures to increase consumer choice of quality providers, is parallel in concept to the federal government's proposed value-based purchasing program model for home health agencies. This is a more dynamic approach that creates opportunities for the development of high-quality home health agencies in response to changing needs of the population and the marketplace. It permits gradual growth of quality agencies, both existing Maryland providers as well as those new to Maryland. It focuses on consumer choice of quality providers and will include qualifying factors for both a jurisdiction and for an applicant agency. Since these qualifying factors focus broadly on quality measures, I will now turn it over to Carol to discuss the state of the art in quality measurement for home health agencies.
This is an abbreviated version of a much longer presentation that was discussed at the first Home Health Advisory meeting that was held earlier this month. The first thing that we did was talk about the state of the art in home health quality, and these are the nationally reported National Quality Forum endorsed home health quality measures. There are process, outcome, potentially avoidable event measures are actually outcome, but CMS reports puts them in a special category, primarily I think because they come from a different source. They come from claims data versus OASIS data. And patient experience of care. The process measures look at care given, outcome, the result of care, and patient experience is the patient report. There are a total of 22 process and outcome measures and 5 composite measures that are reported for home health CAHPS. This is a list of the process and quality measures that are listed on the Consumer Guide to Long-Term Care and also on Home Health Compare. They are arranged in categories, as you can see. And this is mostly for your reference so that you can see what all 22 of those measures are. And the next slide shows the CAHPS composite. There are 2 overall measures, which are the same measures as we spoke about earlier when we talked about the short stay survey, an overall rating, a likelihood to recommend, and then composite measures that consist of giving care in a professional way, communication, and discussing medications, pain, and home safety. This is a picture of the home health quality measures as they appear on the Consumer Guide. They are listed by category. The user can select the home health agency, look at the score and the Maryland average, and they can also compare with other agencies. CMS proposes the following criteria, and these are the criteria that we're proposing would be used for Maryland to select performance measures. It should apply to a substantial portion and have sufficient data for the majority of home health agencies. It should show a reasonable amount of variation, and it should be possible for a home health agency to show improvement. We would want to avoid the so-called topped-out measures where every agency is performing it, 99% or better. Measures should have high face validity and clinical relevance and stable and not show substantial random variation. This is the key slide in the proposed methodology for qualifying an agency for CON in Maryland. We would use selected measures, not all. It would be a combination of process, outcome, potentially avoidable event, and experience of care. We would then determine a benchmark score for each measure. The benchmark could be the state average. It could be a national average. It could be something else. Track performance over time per agency. And then qualifying factors would relate to not just achievement of the benchmark, but also showing improvement. The specific measures, the benchmark scores, and the degree of improvement would need to be determined, and that's for discussion at a future meeting. Lastly, the CMS is expanding the 5-star rating program. They've had it for nursing homes for several years, and this year they've rolled out dialysis 5-star, hospital 5-star is in the process of rolling out, and home health agency 5-star is projected to roll out beginning this summer. These are the measures that CMS is proposing to include using their criteria. They've all met the criteria set a few slides ago. you will see the absence of home health CAHPS measures. However, CMS has been proposing feedback sessions, and that was offered as considerable feedback, and they have announced that they will include home health CAHPS measures, but probably not in the initial rollout. The initial rollout will be the outcome and process measures, and later on this year they would include experience of care. So in terms of the home health planning process, this is the address to use to follow what is going on, and we will post future documents and on the MHCC website. I'd welcome any comments you might have about the proposed methodology.
Questions or comments?
This is Leahy. I have a question.
Dr. Peralta.
Oh, great. I'm not on mute now, so thank you so much. I have a question about, since now we really are putting so much emphasis, and CMS is too, in terms of coordination of care, and one of the major issues and barriers that has happened is the lack of coordination of care with the primary care physicians or the hospitals where the patients come and go. And I'm wondering if this is going to be part of the scoring system or something that is going to be present really to be able to account for the safety and, you know, the decrease of probably reduction of readmissions for our patients, because that coordination is really becoming critical at this point.
The home health CAHPS measure has some transition questions. They're not as specific as the ones that I showed you in the short stay, but those are the only measures that I'm aware of at this point that have been nationally tested. If you know of any, please let me know. I'm not necessarily proposing that we would use the CMS measures totally. We may adopt those as core measures, and Maryland could then adopt additional measures as we see fit. But that seems to be a good core set of measures for home health quality.
Great, because now the systems are not speaking to each other, and that could put our patients in jeopardy. So that would definitely, I would be probably sending you some information about that perhaps could be incorporated in the future.
Thank you.
Question around the CON standards and methodologies and appropriateness. So as you showed in your graph, you know, one of the big issues in this whole area is you know, not whether the patient should get home health services, but what the right dosage is of home health. And you showed data that shows that the visit intensity increased by about 25%. How are you trying to incorporate that into determining what the right needs are?
I think there are a couple of parts. One is CMS is concerned nationally about fraud and abuse. That hasn't been a case in Maryland, but it has been in some other states. So they monitor fairly carefully what types of patients are referred, how long they stay in home health, and making sure that they meet the requirements that they're homebound, that a physician orders this care, how long the care is needed. In terms of utilization, although there has been some increase, historically, Maryland's utilization has been lower. Several years ago, we were much lower than the national average. Other states have come down considerably, and we're now closer to the national average. But on average, our use rates have been low.
So first of all, it probably won't surprise anybody. I think it's wonderful to include quality performance measurement and expectations in the CON process. Can you talk a bit about, I understand how this could apply when one is applying for renewal of a CON, but what about new? How, if you could talk through how, just logistically, how it might work.
Well, it wouldn't be renewal of a CON. It would be applying you could be an existing agency and apply for a CON in a jurisdiction that you don't currently have the authorization to serve, and then you would have a track record. You could also be a home health agency that's existing in another state, and so you would have some national quality measures, but not have a history in Maryland, but still could show what your performance has been. There are also RSAs that are not home health agencies or not operating in Maryland as home health agencies.
Explain what RSA is.
Residential service agencies that are a different type of licensure category. They may also have quality measures that have been used. So we will try to look at a variety of measures to try to show that this would be a good performing agency.
So I think it's also important to emphasize that as part of the work group process, we expect that there will be proposals coming from work group representatives. This is sort of a framework, but there may be different ideas that we will want the work group to consider as well. So, but I think we would encourage folks to think of this within the framework of flexibility and expansion based on quality, demonstrated quality as key elements that we think is important going forward.
Thank you very much.
Thank you.
Ben, you're going to provide us with an overview of upcoming initiatives.
Thank you. Per usual, my forecast on meeting time was a little bit off the mark, but we're close this time. Just a quick note, on February 25th, I believe all of you have already been notified that the Healthcare Commission will host a telehealth symposium. We expect that we'll have good representation from not only the purveyors of the demonstration projects, but also some legislative representatives as well. The 3 demonstration projects will each present the results at hand, and then we'll have some presentations by key stakeholders in the telehealth community here in Maryland. We're also consistent with our presentation today. I want to remind everyone that we'll have a work group meeting of our Cardiac Services Advisory Committee that was set up as part of the regulations we adopted last year. They'll be focusing on external review processes. External review for PCI was one of the key elements of our oversight processes going forward, and we'll be getting input on the best way forward. For next March, for the March meeting, we'll be having a presentation by Teresa on the changes that we'll be making in the health plan performance guide. Teresa and Charmaine will do that. We're embedding that in the broader Maryland healthcare quality reports beginning in 2015. Hope to make full progress, but we'll have to wait and see on just how quickly we can do all of that. We'll have a CON review session. I know we haven't talked as much about hospice recently. Well, that's going to change in March. We'll have a applicant from Washington County come forward with a proposal for an inpatient hospice. We'll also be looking at changes to the electronic pre-authorizations regulations, and the Commission will ask you to approve our MHCC data release standards that we'll be discussing in work group session later today. And as always, we'll have, I'm sure, some additional legislative issues to discuss. So I think it will be a action-packed agenda in March, and we'll keep you informed as we go forward of the of legislation as it develops. Okay.
Thanks, Ben. And Diane?
Yeah, thank you. I appreciate that. When the discussion happened regarding the nursing home short stay survey results, and I suggested that this would be of interest to consumers to be able to look at a facility-by-facility basis, although the response was that this information is on the web, What's on the web is the report, which is a policy paper that's rolled up data, which wasn't my point. My point was on a facility-by-facility basis. So I just wanted to correct the record on that. It's great that the policy paper is there, but that's not something that consumers necessarily would find useful.
I can understand.
So the short term, it would be great if somebody would show me where the short term stay information is. Thank you.
Terrific. So actually, I have a person that may be actually perfect at that. I wasn't going to mention this, but I will now that in the midst of our presentation to the Health and Government Operations Committee, Vice Chair or Deputy Chair pointed out she couldn't get to the website, and Teresa Lee quickly pointed out how she could. So if I snap my fingers, I bet Teresa can find that, how to get to that nursing home location. But we'll help you definitely after the meeting to show you how you can do that.
That's what happens when you elevate your standards there. So, all right. If there's no other motion, no other business, I'll entertain a motion to adjourn.
So moved.
Second? All right. All in favor? Meeting adjourned.